Thanks, Rob. Okay, those are my disclosures again. So I think these demographics have already been reviewed. You know we're dealing with a very serious problem in our country and worldwide. When we talk about chronic venous pathology, we're basically talking about two components, either obstructive disease or non-obstructive reflux. And no matter how you slice it, it's all about venous hypertension causing post-thrombotic syndrome. And you'll see here, the greater the ambulatory venous pressure, the more significant the post-thrombotic syndrome and the complications. And just some basically technical points. The more central occlusion, the higher the chance of post-thrombotic syndrome. The more central the occlusion, the higher the ambulatory venous pressure. The higher the ambulatory venous pressure, the more severity of post-thrombotic syndrome. And that does not mean that when you have infrainguinal chronic occlusive disease that it's always benign. And obviously, post-thrombotic syndrome can be quite devastating. Current standard of care is, as we've heard before, anticoagulation, compression stockings, elevation, and wound care for more serious ulcerations, which is absolutely not sufficient. And a lot of patients are told there's nothing we can do about this. If we're going to consider intervening, our goals are to reduce luminal obstruction, restore flow, again, from ankle to right atrium, reduce the venous hypertension, reduce or improve significantly the severity of post-thrombotic syndrome, and of course, improve quality of life. So thus was born the ACCESS PTS trial. And this was a catheter-based trial for post-thrombotic disease. Here's our steering committee that I was fortunate to participate on, and here's our study sites. And what this is, it was a prospective, multi-center, single-arm trial evaluating the safety and efficacy of endovascular recanalization, which included the use of the EKOS device in patients suffering from chronic DVT and post-thrombotic syndrome. And patients had to have their chronic DVT for at least 6 months, and we enrolled 81 patients. The power for the study was calculated to be 70 evaluable limbs to have a statistically significant result. So our inclusion criteria were that you had to have the DVT greater than 6 months, you had to fail conservative therapy, you had to have a Villalta scale of at least 8. We excluded isolated iliac vein DVT, and we excluded patients who had, more than 3 centimeters involving their cava, and of course, high bleeding risk because we were going to use EKOS thrombolysis. Our primary endpoint was reduction of at least 4 on the Villalta scale at 30 days in at least 50 patients. And our primary safety endpoint was typical, bleeding at within 72 hours of the procedure and PE within 30 days. There were a variety of secondary clinical efficacy endpoints, basically following Villalta out to 1 year, as well as quality of life outcomes out to a year. Our protocol was that these patients were started on low molecular weight heparin pre-procedure. The whole idea was, again, to establish inline flow. You had to cross the occlusion successfully. You would angioplasty the occluded veins, either posterior tibial, popliteal, femoral, iliac to the appropriate size, and you would place an EKOS catheter. You would run the thrombolytic at between 0.5 milligram and 1 milligram an hour overnight, and then you would do follow-up angioplasty and stenting as appropriate. Patients were discharged on low molecular weight heparin for a month and then transitioned to oral medication. Patients had to exercise, and again, we had follow-up. Now, people say, well, what's the point of EKOS here? And at the very beginning of the trial, what we looked at is on a pilot study to see, did EKOS actually make a difference? So what we did is we looked at patients who the occlusions were crossed, angioplasty was done, and did EKOS make a difference in the amount of clot? And you can see there from the chart, the answer was yes. We basically enrolled 81 patients of the over 1,200 who were screened. There were 4 bilateral patients. 78 were treated for a total of 82 limbs. And here's basically our results. The average DVT was 13 months old. The TPA dose, again, for an overnight infusion, mean dose was 18.5. And you can see it was an overnight infusion. Adjuvant therapy was done in 95% of patients. We did have to do revascularization within 30 days in 6% of patients, or a total of 5 limbs. You could see more left than right. The mean hospital stay was 2 days. Our primary endpoint was reached in that we had a goal of at least reduction of 4 points in the Villalta scale at 30 days in 50% of patients, and actually we saw that in 67% of the patients. These were the Villalta results in that we saw a statistically significant reduction out to a year, and you could see a pretty significant improvement at 30 days, which carried out to a year of almost 50% improvement in their Villalta scale. And there in the chart you could see statistical significance in each one. As far as VCSS, again, we saw very similar results. You know, this is a different scoring system to evaluate chronic venous disease, and we saw about 43% improvement from baseline at 1 year. And you can see, again, that started at 30 days and carried out to a year, again in the chart. And as far as quality of life, we saw a statistically significant improvement out to a year of 37%, and here in the chart. Doppler patency in the areas that we could evaluate, so you know Doppler doesn't always do a great job in the iliacs. You'll see that over 90% in most of the segments at 30 days with patency, and again at 1 year, similar results. This looked at the EKOS result to say, okay, after angioplasty, did we see improvement in the washout? And the answer was no, but after EKOS, we actually did. And then, of course, after therapy, we had even better flow. There was 1 major bleed in the whole trial and 3 recurrent DVTs and 1 PE at 30 days. So, in summary, this was a statistically significant study in that our primary endpoint was reached in 67% of patients. We saw that Villalta scale improved to about almost 50% at 1 year. VCSS improved to 43% at 1 year, and the quality of life improved by 37% at 1 year. So, in conclusion, endovascular recanalization in patients with chronic DVT with moderate to severe post-thrombotic syndrome with EKOS thrombolysis, angioplasty, and stenting is safe and effective. We saw the statistical significant improvement in both the post-thrombotic scores and quality of life. And really, this was the first trial that's ever looked at these group of patients. And I think that this shows us that there is hope for these patients who have suffered from post-thrombotic syndrome and failed the standard of care. I think we're out of time. Right, so there's my case. Okay, thank you.
Thanks.